During the first few weeks of a new health IT project, there's usually a feeling of excitement and confidence in the plan. The timeline has been set up, resources have all been allocated, and everyone has a shared picture of what is supposed to happen. Unfortunately, if you lead, coordinate, or support health IT projects, you know that feeling doesn't always last. I've worked on a lot of projects over the years, as a project manager on the leadership side and as a clinical applications team lead. There are three patterns that almost always result in some sort of plan adjustment. I want to go over them today so you can recognize them sooner and manage them with less stress. The first one that I want to talk about is when work starts slipping, but there's no realistic way to extend the timeline. In healthcare, implementation dates are usually tied to things like regulatory deadlines, fiscal years, or vendor commitments. And these aren't going to move just because something is taking longer than expected. Since most timelines aren't set up with a lot of buffer in them, when the plan stops lining up with the calendar, less experienced teams can quickly start to feel overwhelmed. That's when you need to start making real project decisions to try to connect back to that timeline so you can successfully go live on the intended date. You can start to look at things like having test scripts and training materials started before the build is complete, or you may consider things that were initially laid out sequentially being done in parallel or perhaps with just a slight lagging. At first, it might look like there's no wiggle room at all, but that's where you need to lean on the people that are around you. Your application and technical leads, trainers, and integration teams have all been through this before. Pull them in and ask them where work can safely overlap and where it absolutely can't. If they aren't sure, chances are your vendor team has seen other organizations go through the same kind of challenges, so they might be able to provide you with some guidance. When you're trying to make up time, it's important to know that it's not going to be a one-time plan adjustment. You're going to have to actively continue to adjust things until you can get yourself back to a more stable place. Strong project teams are not the ones whose plans never move. They are the ones that keep coordinating, resequencing, and checking dependencies so that the project manages to stay on track even when the schedule is under pressure. Setting the timeline aside, the second pressure that shows up in almost every single health IT project is clinical and operational engagement. In the earlier stages of a project, subject matter experts and clinical resources usually have time set aside and it's somewhat protected. But as the weeks and months go on, that protection starts to fade. Other initiatives start up, operational priorities change, and care delivery always takes precedence when something comes up. The project is still important, it's just not the only thing that's competing for their attention. So to help manage this, you want to be intentional with every interaction. Any meeting that you have with operational or clinical resources should have a clear intent and purpose. If people are expected to come to meetings ready to make decisions, make sure that they have materials in advance so they can use small windows of time to prepare themselves for the discussion. You also want to keep checking to make sure you have the right people in the room. If key resources stop attending or you only have partial representation, sometimes it makes sense to pause and reschedule, rather than move forward with gaps and create rework for everyone later. Just like pressures on the timeline, you always want to be looking for ways that you can do things more efficiently. If the build team needs something reviewed and the technical team has the questions for the exact same group, bring them all together, do it at the same time. That way you don't have to try to coordinate two separate meetings with the same clinical audience. This one can be kind of challenging because IT teams tend to think in silos, but to the clinical and operational teams, it's all one big project. So the more you align your coordination to that reality, the easier it is to keep them engaged. Now, even when you manage the timeline well and keep your operational and clinical resources engaged, there's still one more pressure that always shows up in IT projects, and that's the fact that your project is not the only project that everyone's working on. Health systems are always running multiple initiatives at the same time, and they also have operational activities to worry about. So the same application teams, the same technical, trainers, integration resources, and clinical and administrative SMEs are pulled into multiple different things and juggling all sorts of balls at the same time. When the project plan is set up, you almost always take that into consideration. However, as the project moves on and you start to make tiny shifts in your schedule or move meetings around here and there to accommodate other things, it's important to note that the other projects are probably doing the same thing. So your coordination that you set up at the beginning of the plan may no longer align with those other initiatives. So the capacity that you thought you had may not be there, even though you haven't done anything to impact it yourself. That's why it's not enough to just look at those resource conflicts at the very beginning. You have to continually look at them throughout the project plan. That means making sure you have a way to hear about changes to other projects as they're happening. In some organizations, that comes from regular PMO meetings. In others, they might use shared tracking tools for all their project management activities so that you can just log in and check to see where everyone's at. Of course, hoping that everyone keeps those up to date. You also can schedule short touch points with the application, technical, and integration leads, because chances are pretty high they're going to be involved in a bunch of other projects and they can usually tell you where things are shifting. It also works the other way. If there's things happening on your project that are causing your schedule to change, some of your engagement with administrative and operational staff to shift a little bit, or your testing to move, for example, then it's important that you let the other project managers know so you're not going to collide with them down the road on different things in their projects. When you take a step back and look at these three pressures together, it's easier to understand why health IT projects require active management. It's great to think that once we set up a plan, it's just going to follow the happy path, but in reality, that's not true. There's almost always some sort of pressure to the timeline. Clinical and operational resources can get harder to secure as the project moves along, and changes from operational activities or other initiatives around you can impact the best intentions that you set out. That's why leading health IT projects can feel very demanding and sometimes overwhelming, even when things are going well. Strong project leaders aren't ones who avoid these pressures. They're ones who recognize that these pressures are going to occur and manage them with intention, coordination, and support from the people around them. That means actively managing the plan as it shifts, resequencing things as you need to, and being very deliberate about stakeholder time. It takes time to develop the skills, but over time they get easier and easier, and it just becomes second nature to manage your way through things. I hope going over these three pressures has helped, and the next time you're leading or coordinating a health IT project, you can keep them in mind as you set things up and as you manage your way through the initiative. I will see you again next time.